Breathing and temporomandibular joint disease. Migraine, tension headaches and temporomandibular pain can be associated with breathing pattern disorders. Temporomandibular joint disease, it refers to a collection of pain-related conditions in the masticatory muscles and temporomandibular joint. Occlusal factors have been implicated in TMD pathogenesis, but despite decades of research, there has been no causal relationship between occlusal and TMD. Another factor is that the tendency of temporomandibular joint disease to improve with the passage of time, regardless of the treatment modality, has hampered research. The condition, it appears self-limiting and it's associated with no significant long-term disability in the majority of patients. Even when patients were followed up for 20 years, the end result of TMD is often not incapacitating. The significance of psychosocial factors in both the assessment and the long-term management of patients with TMD is receiving increased recognition. The International Association for the Study of Pain has defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Chronic pain is pain that's lasting for longer than 6 months. And emotional factors are more significant in chronic pain than in acute pain. They exert a significant influence that has to be recognized and addressed in order for effective management of chronic pain conditions, including orofacial pain, to take place. Psychological factors are well recognized risk factors for temporomandibular joint disease. Depression, sleep disturbances were shown to be significantly higher in TMD patients as compared to controls. Now, one could argue that it's the pain as a result of the temporomandibular joint disease which is increasing depression. But could it be that other factors which are increasing to anxiety, stress and depression are also feeding back into temporomandibular joint disease? Significantly, the teaching of relaxation skills and coping strategies are effective proven TMD therapies. Results from clinical trials that included long-term follow-up data show that cognitive behavioral therapy intervention causes a significant decrease in the pain self-reports and pain interference in daily activities. In a study that involved 1,149 TMD patients from 3 highly specialized university-based centers, pain-related disability was found to be strongly related to depression levels as well as pain duration following 6 months. Respiratory symptoms are common in people suffering from anxiety and depression, and breathing re-education is an effective treatment for both depression and anxiety. There's always a link between respiratory symptoms, breathing pattern disorders, and how it feeds into stress. Of course, it's recognized that under stress our breathing changes, but also if we have developed a breathing pattern disorder, which is including hyperventilation, fast breathing, thoracic breathing, that in turn will lead to an increase of stress, anxiety, depression, and poor sleep. Breathing is influenced by emotions and the limbic system. In stressful situations, the limbic system activates the fight or flight response, and the breathing pattern can change from diaphragmatic to thoracic breathing. The corresponding increase in respiratory rate and in minute ventilation leads to a hyperventilation state where by definition the increase in respiratory rate exceeds the metabolic demands of oxygen and arterial pCO2 levels are lowered. So hyperventilation, basically it means breathing in excess of normal metabolic requirements of the body. A consequence of hyperventilation is lower arterial CO2 levels. TMD patients, when compared to controls, have a similar breathing rate, but a significantly lower end-tidal pCO2, indicating that TMD patients hyperventilate, creating a respiratory alkalosis. Now, you might wonder how they have a similar breathing rate, but significantly lower end-tidal CO2. Isolating breathing can be problematic, and also isolating carbon dioxide, because carbon dioxide tends to fluctuate. You could have one individual with a breathing pattern disorder and upon examination they show relatively normal breathing. But it may be just that they have a periodic sigh every few minutes. That could be enough to maintain hyperventilation. Just looking at the respiratory rate alone is not sufficient either, because when we're looking at minute ventilation, we have to consider both the respiratory rate and the tidal volume. So the respiratory rate multiplied by the tidal volume gives us minute ventilation. So the key area here is to understand what is minute ventilation. Hyperventilation seen in temporomandibular joint disease, it can be regarded as part of the fight or flight response. And this was coined by Walter Cannon back in the 1930s. It's characterized by increased sympathetic nervous system arousal, increased central nervous system arousal, and increased skeletal muscle activity. Hyperventilation is causing too great a loss of carbon dioxide, and this in turn is increasing pH in the blood, respiratory alkalosis. The increased pH enhances the likelihood of motor unit neuron depolarization or excitation, contributing to increased central nervous system arousal. The increased neural excitation associated with central nervous system arousal contributes to increased muscle tone and muscle spasm. In chronic respiratory alkalosis, renal compensatory mechanisms excrete bicarbonate HCO3- in order to return the plasma pH back towards the normal range. So basically what's happening here is the individual, if it's short-term hyperventilation, the individual hyperventilates, their CO2 level in the blood lower, but after the hyperventilation stops and their breathing normalizes, carbon dioxide normalizes. That's fine. However, in long-term hyperventilation, the individual is breathing hard, they're losing too much CO2, carbon dioxide in the blood is lowered, this is increasing blood pH. But the body wants to have normal blood pH of 7.365. If blood pH doesn't normalize quite quickly, what happens is that the kidneys will step in and the kidneys will dump bicarbonate in order to bring pH back towards normal. So bicarbonate is sacrificed in an effort to normalize blood pH. But the problem now is lower carbon dioxide but lower bicarbonate. The systemic loss of bicarbonate from the intracellular and extracellular fluids reduces the body's ability to buffer any buildup of metabolic byproducts such as lactic acid in the muscle tissue. Bicarbonate is a necessary buffering agent in the blood in that it reversibly binds with hydrogen ion to help reduce acidity. In this situation, the skeletal muscle fatigues more readily due to the buildup of lactic acid. In this paper here, a study to evaluate and correlate temporomandibular joint disease, cervical spine disorder in asthmatic and non-asthmatic children. They looked at 30 asthmatic children, 30 non-asthmatic but predominantly mouth-breathing children, and 30 non-asthmatic predominantly nasal breathing children. Both the asthma groups and the mouth-breathing groups demonstrated palpatory tenderness of the posterior TMJ. The medial and lateral pterygoid and trapezius muscles when compared with nasal breathing group. Results showed a positive correlation between the severity of temporomandibular joint disease and the cervical spine disorder signs in asthmatic children. Another factor in terms of breathing pattern disorders in temporomandibular joint disease is that mouth breathing is associated with using the accessory muscles of respiration. When used as accessory muscles of respiration, the sternocleidomastoid and mastoid muscles not only lift the chest upwards, but also pull the head forward. One will develop, or more likely to develop, forward head posture as a compensatory mechanism as a result of oral breathing. In this situation, the scalene and parasternal intercostal muscles, they also flex the neck. The distance between the upper and lower teeth with the mandible in rest position is called the freeway space. A forward head posture leads to a decrease in freeway space. Dental splints, they increase the freeway space. They reduce the pressures on the temporomandibular joint generated by clenching. Correspondingly, a reduction in freeway space through mandibular evaluation results in an increased pressure on the temporomandibular joint itself. So the association here is that breathing pattern disorders causing mouth breathing, causing forward head posture, leads to a reduction of freeway space. A reduction of freeway space in turn leads to increased pressure on the temporomandibular joint itself. Mouth breathing can lead to forward head posture with alteration in mandibular position. In children, mouth breathing is associated with increased masticatory muscle tenderness. Forward head posture is also believed to alter occlusion, lead to increased posterior tooth contact and increased temporomandibular joint compression, all anatomical changes emphasized in temporomandibular joint disease. Correction of the head and cervical posture, which increases free waist space, is considered important in TMD treatment. The restoration of diaphragmatic breathing is also an important musculoskeletal and psychological therapy used in correcting forward head posture and in helping patients suffering from TMD. Nasal breathing is directly associated with diaphragmatic breathing. Now, it's not just enough that if a person has been mouth breathing for a period of time, just switching to nasal breathing won't necessarily activate the diaphragm. We also need to do breathing re-education to help improve diaphragm functioning. Bruxism, the habitual grinding of the teeth and jaw clenching, has also been linked to temporomandibular joint pain. The repetitive loading and unloading of the joint involved in bruxism would also lead to hypoxia perfusion injury within the TMJ. Awake bruxing, as opposed to sleep, is associated with stress, anxiety and depression. And once again, this is tying in the need for helping to change and reverse anxiety, stress and depressions in these individuals. Therefore, the masticatory muscle pain seen in TMD may be secondary to the interplay of a number of factors. Postural changes associated with a forward head posture, which place some masticatory muscles in shortened positions and others under chronic tension in a lengthened position for prolonged periods, would be a factor in muscle trigger point and pain development. Prolonged peripheral pain leading to changes in pain processing at a central level. A number of experiments have also shown that anxiety, which is linked to alterations in breathing patterns, lowers pain thresholds. In an experimental situation, slow breathing rate results in reduced pain intensity and unpleasant ratings to pulses of painful heat. Females are able to generate significantly higher TMJ pressures during clenching than males. During the second part of the menstrual cycle, after ovulation has occurred, women have a greater tendency to hyperventilate, lowering arterial PCO2 levels by 6.5 mm of mercury pressure. Now, this is a significant reduction in arterial CO2. Normal is 40 mm of mercury pressure. To lower it by 6.5 is certainly bringing it into hyperventilation. Even if you were to go from normal of 40 down to 33.5, it's very significant. In the second part of the menstrual cycle, progesterone is secreted. Hormone changes lower arterial CO2. In females, TMD pain rises towards the end of the cycle and peaks in the first 3 days of menstruation. A secondary peak in pain also occurs around the time of ovulation. TMD pain, it occurs at the time of low or fluctuating estrogen. Estrogen and progesterone both influence minute ventilation and arterial PCO2 levels. The hormonal intricacies relating to pain and the menstrual cycle are still being untangled, and this is as recent as 2010. But alterations in breathing pattern during the menstrual cycle could contribute to TMD. While it has been reasonably postulated that the forward head posture leads to increased pressure in the joint, this part of the picture has not yet been scientifically proven. Attention to breathing and postural correction provides healthcare professionals valuable additional tools to help care for patients with TMD. In summary, we have to recognize the psychological factors associated with temporomandibular joint disease. Breathing pattern disorders will certainly activate the fight or flight response. The individual, number one, their sleep is affected. They're more likely to be tired, they don't have focused concentration during the day, they're more likely to be agitated. Number two, breathing pattern disorders is causing too great a loss of carbon dioxide or increasing the body's sensitivity to the gas CO2. With respiratory alkalosis and the compensatory mechanism of the kidneys dumping bicarbonate, buffering capacity is increased. and as a result lactic acid can increase, and this can contribute to muscle pain. A third factor is awake bruxing, and this in turn would be related to anxiety, stress and depression, with the individual clenching down and putting pressure on the temporomandibular joint. A fourth factor, as a result of mouth breathing leading to forward head posture, and forward head posture leading to a reduction of freeway space. With a reduction of freeway space, the compression on the temporomandibular joint is greater. A fifth factor in terms of females with change of hormone and resulting impact and change in carbon dioxide. So taking everything into consideration, in the treatment of temporomandibular joint disease, breathing patterns and breathing pattern disorders have a role to play.